So this week, as I said, week 8. This is the week we're going to go over GI and GU. I did send you a really great matching sheet out that really goes over, if you open your book and you look at all the topics that you need to know are right there. So I actually made it for a quiz for one class when I was on ground with peds. And I just liked it so much. I think it keeps you organized with GI, GU, and what you're expected to understand out of all of that. So again, Kaplan, the math assignment is called Kaplan Advanced Math Peds A. There is an advanced math that was done in pharmacology. This is a different one that you have due. Also, quiz 5 is due Sunday, your NCLEX questions. And then you have your diabetes case study, which is due also. Your project is due on Sunday. Most of you have come through me and asked, what your topic was. Again, if you get them in early, I'm looking at them, telling what you need to change in order for you to get the best grade possible. I mean, I'd like everybody to get 100 on it. It is 6% of your final grade. It is a big chunk of subjective grades. So it is a good thing to get a good grade on. And I'm finding some really good projects out there. So they're actually fun for me to read, especially when they're projects that these diagnoses I've never heard of, because I don't know everything. I don't know all of the syndromes and whatnot. So I've been hit with some pretty nice stuff. So I want to thank those students who are doing that. So this week, we're going to go over our PowerPoint, then we're going to go over our Kahoots. So let's all get started. Anybody with a problem, question, concern? Okie doke. So let's go ahead for our PowerPoint. GI, GU, a lot of stuff in this for children. So GU, genital urinary tract disorders. Well, when you think of urinary tracts, you think of urinary tract infections and children. This is really due to those toddlers who are trying to get potty trained, is where we see most of them. You might see a child, start to frequency in urination, or they're burning or like going ow as they're, urinating. You also might smell, especially your infants, you might smell the urine. Sometimes it's only when they get the fever on an infant that you'll go and you'll start checking for a urinary tract infection. Uncircumcised boys are more apt to get urinary tract infections, because if the parent doesn't every day pull down the foreskin and get rid of that schmegma in there, it is like a petri dish and it grows bacteria. And of course, then it goes into your urethra, into the bladder, and there, urinary tract infection. So uncircumcised boy are more frequented. And we know girls, potty training, they're not wiping front to back. Of course, that's going to cause it. So who are those children and what do we need to teach our mothers regarding this? Well, any child who's incontinent and they're already potty trained, there's something not right. Something's wrong. Of course, if it's small, that strong or foul smelling urine or frequency, urgency, those are things that are gonna, put you, maybe it could be. And infants, even if they have a fever, they're gonna check everything, including urine. So prevention, well, we need to immediately get treatment if we see something. That's the best way to be taking care of your kidneys, making sure they're not gonna get really bad infections and go into some bigger disease problems because we didn't treat a urinary tract infection. Children need to be taught, parents need to be taught how to wash the hands, how to wipe front to back, very important things. And we don't think about the adolescent urinary tract infections, but I will tell adolescent girls, usually without the mother there, that if they are having sex, that some way that they can help prevent them having urinary tract infections is to urinate as soon after sex as possible. And that does decrease the frequency of urinary tract infections. So how do we diagnose urinary tract infections? I mean, on the last exam, we had a question regarding infants and the best way to get an accurate specimen. And the answer is to catheterize. And you're thinking, well, you're taking this is a question about a 5-week-old infant. You're like, isn't that a little bit brutal? Well, think about a 5-week-old infant. They don't have any immune system except for what mom's given them. They haven't gotten any sorts of immunizations yet. So infection is a big deal and needs to be treated as quickly as we can, because a urinary tract infection can become urosepsis very easily. So if we've done a catheterized urine specimen, we know that whatever urine we get, it's going to be an accurate specimen. And we can make sure that the antibiotic that was ordered is covered by whatever that urine is growing. So we are actually protecting this infant from worse conditions that can be caused by urinary tract infection. Now, we use an 8 French catheter for catheterizing these children. It's actually the same one we use for adults. It's also with women, not men. Men, we usually can't do just a straight cath with those little tiny little tube catheter kits. But we use actually the same size for infants or female. It's the same thing. Now, if they're premature, there's no way that we can use the catheter. It's not going to fit. So what we do is called the suprapubic aspiration. The suprapubic aspiration is done when we suspect urinary tract infections or we're seeing signs of sepsis or infection in that premature infant. And they clean the area above the symphysis pubis, and they take a needle and go directly through the abdominal wall. And it goes directly into the bladder. And a half an ml, a half a cc is all you need, because really all we want is a really good culture to make sure that we are placing this child on an accurate antibiotic. We can also do kidney taps, looking at kidney infections. We can do bladder washouts, looking for what is that sludge in the bladder? Is that part of the infection? We can do ultrasounds, looking at anatomy. We will be doing voiding cystourethography when you have that child with frequent urinary tract infections, because it could be due to some structural stuff going on. It could be a kink in the ureters, could be reflux going, the little valves aren't working and we're going from the bladder or the vesicle up into the ureters. So you have vesical ureteral reflux, and that can go into the kidneys and really cause really bad infections. And then we have the IVPs and whatnot, and they usually are for stones. So renal biopsies are done, and these are done for those children with those chronic, infections, and we don't know what's going on. So they might opt, if they are constantly treating, they might opt to do this biopsy. Now, renal biopsies do hurt, and we need to be honest with our children, but these children are medicated. They are given something for sedation or pain before to make sure that this uncomfortable feeling is going to be minimal for them. So when it is done, remember, we've stuck a needle through the skin in the back right into the kidney. So there can be some leaking from the kidney into the peritoneum, okay? Or it could come out and just be on the bed there. So post-renal biopsy, these dressings, again, pressure dressing like cardiac cath, a sandbag if we can, just like a cardiac cath. These children, because of the chances of the clot from the kidney, hole that we stuck in there, with the leakage inside, we want them bed rest 24 hours. We don't want that clot to fall off, and we don't want any undue side effects that we don't need. Now, we are going to watch, even if they're on bed rest and they have, they're on bed rest and they've got a pressure dressing on, we're still going to be monitoring them to make sure no urine's going into the peritoneum, which would be abdominal pain, tenderness. And of course, intake and output. If our output is decreasing, where is that urine going to? We need to look out for. And of course, infants require a little bit more. And I've never seen a small infant with a renal biopsy. They're only older children, but it can be done if we need to. So I mentioned a little bit about obstructive uropathy, which is like a kink somewhere, in the anatomy of the genitourinary system. So it could be backflow into the kidneys themselves, which causes hydronephrosis, or it could be from the vesicle, which is the bladder, up into the ureters. Could be partial, could be full, it could be one side, two sides, and what you're doing is you're taking urine from the vesicle, the bladder, and it's going back upwards. And they say that the urine in the bladder is not as sterile as the kidneys. So you're putting maybe some slightly contaminated urine back into the kidneys, and that causes the big problems, urosepsis, and can cause the kidneys some really bad damage. So these are your pictures, and it shows you where those things could be and for why, and the pictures in your book. Now, nephrotic syndrome, I'm going to say one thing twice, has nothing to do with renal failure. Nephrotic syndrome has nothing to do with renal failure. Nephrotic syndrome is the body's inability to hold on to protein, and the kidneys just lose it, get rid of it, get rid of it, get rid of it. So what do you see? Well, you'll see all the protein in the urine, and then all of the protein in the blood and the intravascular is also going to be depleted because we filter blood through the kidney, and they like the protein, they take it out and they spill it in the urine. And then another thing is hyperlipidemia. So looking at the cholesterol, you'll see. And because we've taken all that albumin or protein, it's the same thing, albumin is protein, we've taken it out of the intravascular space. What happens is fluid seeps into the extracellular spaces. And what do you see? Edema. You can see edema of the eyes. Usually you'll see it puffy around there. The normal edema, the hands, the feet, the legs, but it can go further, going into swelling of the tongue and the inside of the mouth. That even inside the mouth is very painful because of all of the swelling. I mean, our way that we treat this in an acute stage is actually steroids, okay? But the other thing that we treat at a chronic all the time is to always monitor them for infection. They're immunosuppressed. These children, we need to be careful, hand washing, etc. with them. Now, they have that loss of appetite because of that swelling inside their mouth, and they can't eat, and it hurts, and they bite down, and they're biting their mouth and their gums. Salt restriction, fluid restriction, they're swelling, whether it's due to protein loss, whatever. We don't want to do anything else which makes that swelling any more than we have already started with, and we already with edema and swelling. What does that cause in any patient? And we have to monitor blood pressures because all of that extra swelling going on there. Now, family needs to know what's going on with this and how to work with it, and to understand monitoring their weights at home and being careful, no salt and fluid restrictions. And, the other siblings need to be aware of why they're doing that. So the acute stage, we give steroids and we get rid of it. During the chronic stage of nephrotic syndrome, because this isn't something you get and it goes away. This is a condition for life, okay? So these children will chronically be on low salt, low fluids, monitoring themselves because they're always losing protein. So we need to monitor this very, very closely. As nurses, as if they're in the hospital because they're in a nephrotic syndrome where they've really lost fluid and they're very swollen, our priority, intake, output, daily weights. We need to be monitoring fluid balances so carefully on them. Now, we've talked about, rheumatic fever. It's caused by strep infection. Well, this is the second condition caused by a strep infection, and it's acute glomerulonephritis. You will usually see this anywhere from 2 weeks to 3 weeks after a strep infection. And what you will see is a decrease or stop in urine. And then, of course, the urine's not going anywhere. Fluid's got to go somewhere. So there'll be swelling. And of course, with the edema is that hypertension. The urine is going to be with blood in it. And of course, that protein's going to be there. So these are the signs and symptoms you will see. So how do we treat it? Well, we're going to treat the strep infection. We're going to be monitoring intake and output. Usually acute glomerulonephritis, we can give the antibiotics, we can monitor their INO and their weights, and we can get it, to be an acute stage, but sometimes it does become a chronic condition. So as soon as we can catch it and start the treatment is best. So manage that edema. How do we do that? Daily weights and take output. And in smaller children, we monitor their abdominal girth because they do carry a lot of weight in their abdomens. The nutrition, like I said, low sodium, fluid restrictions, and again, they are susceptible to infections. Now I put this slide in, hemolytic uremic syndrome. It is something that can occur. It is a kidney disease. It's not that common, but it is one of those conditions where there is a lot of that. It's anemia with thrombocytopenia, but it's a renal failure. And it has to do with GI and E. coli. And what you see is a child with like a urinary tract infection with blood in the urine. And also you see them with vomiting and diarrhea. So it's one that I mentioned that sometimes you do see that. Wilms tumor, we've mentioned before, the nephroblastoma. It's a kidney adrenal type tumor. It is males, ages 3 to 5, African American. And we treat this with surgery, with chemo, radiation, both, and then surgery. The biggest thing with this is do not touch that abdomen. When you touch it, it's fragile, this tumor, and it can cause pieces to break off and metastasis, and we don't want that. So renal failure can be acute or it can be a chronic stage. Now, acute renal failure is usually due to something. Something happened. And if you read the slide, one of the biggest things that causes acute renal failure is dehydration in children. That's why children really need to carry water or electrolyte solutions when they're playing sports and out, and keeping their fluid status up is very, very important. Acute renal failure could be due to things like, you have some structural thing that went on that finally got you to the point of, their kidneys shutting down. I've actually seen one case where it was ibuprofen that caused acute renal failure. It was an older person, still not very old, but an older, and this child had a kidney stone, and they were taking ibuprofen, but too close together, and it ended up in acute renal failure. This guy was scheduled to put in a shunt to do dialysis, and he started to urinate. And that's when they figured out it was that ibuprofen that called it. So finding out the cause is better than treating the symptom. Now, chronic renal failure is a progressive deterioration of the kidney's ability to function. They say chronic renal failure is more than 50% of the function has been destroyed. So these children cannot filtrate, the toxins out of their body. It can be caused from those congenital renal urinary tract malformations, that vesicoureteral reflux, hydronephrosis, but it could be due to hereditary disorders. Now, I worked at doing clinicals at the hospital I worked at, but they put me on the GU floor, and I never worked that floor before, never been floated there, never worked it. And what I found is they had a dialysis unit there. And I was asking the nurses, why are there so many children with chronic renal failure? You would think there's not many. There are. And what it was hereditary. There were many families were doing intermarriage as first cousins, something that cut the culture, that's what they did, and what they found that renal failure ended up being one of the side effects of that. Now, if you're having chronic infections, of course, that can cause you to kill your kidneys and go into chronic renal failure. Lupus attacks organs, again, renal failure. And then anaphylactoid purpura, this is, when you have that anaphylactoid symptom and it goes to your kidneys and it causes your kidneys to be damaged. So what is our goal in any sort of kidney failure? Well, we want to have that kidney or something working for the kidney that can keep the fluids and the toxins, the best that we can. We want to keep the electrolyte balance good. We know potassiums are 6, 7 on kidney failure. Any adult, children don't matter. And also the hemoglobin hematocrits can be really, really low. One of the things that we've started doing is just giving them prophylactic erythropoietin injections. And what that does, it makes the body produce its own red blood cells, which probably can decrease the amount of transfusions that's needed. And we want these kids to be as normal as possible. I mean, if this child is on hemodialysis, and these are your older children, because young children cannot be on hemodialysis. It's just too much blood flow going to the brain and the brain fragility, and they just can't. But the older children who are on this, they're in dialysis 3-4 days a week. So try to keep them as normal, as active as possible is our goal with that. Now, as I said, infants cannot get or smaller children cannot get hemodialysis. There's just too much flow going in and the brain cannot handle it and they bleed into ventricular hemorrhages. So they put them on peritoneal dialysis. And what they do is they take a warm fluid and they inject it into the abdomen. The nephrologist will say, insert 100 mLs into the abdomen over 20 minutes and let it sit there for 20 minutes and then it can drain. Now, these are cycles. When you instill it into the abdomen, it's called your still as it sits, and then the drain, it comes out. Now, peritoneal dialysis is given at night. So it's usually under a machine that's just does it by itself. It's pretty neat, actually. And then at the end of the night, the Foley catheter bag, which handles all of the drainage coming out of the infant, you can measure it. And then you can determine, usually there's 8 or 10 cycles, depending on the doctor, the child, etc., that is done during the night. You can measure the urine, and the difference between what went in and what's in the bag is your urine output. So it does work well. I mean, your peritoneum is your filtration device. So it should be warmed. You don't want to put cold fluid into the abdomen. And the biggest thing that we worry about is an infection or peritonitis. If you have peritonitis, what are you going to use for your kidney? There's nothing left. Okay, all you have is your abdomen. So we really need to monitor that very closely. So what would you see if you had a child with peritonitis? Well, maybe the color of the fluid coming out was clear and now it's cloudy, or you might see some sediment in it, or you might see blood in it, or you might see redness and tenderness in the abdomen and fever. You see stuff like that, the first thing you do, call the physician. There's never a standing order for this. The physician wants to know what's going on so they can monitor it quickly, and they will start antibiotics as soon as possible. I mean, I've seen parents monitor peritoneal dialysis at home and do amazing jobs. This one child, little Willie, chronic renal failure, was born, the kidney didn't work, so he was on peritoneal dialysis. That mother did this for 2 years, the peritoneal dialysis at home, and he finally got his kidney. The child never, ever had an infection. never was admitted to the hospital due to an infection. And the dressings that that mother put on that child are as good as dressings that I would have put there. And I'm a little OCD about everything neat and tidy. So she, you know, gets my hands down, and I applaud her because Willie's an active little boy. So that was nice. So what best describes acute glomerular nephritis? Anybody got an answer?
Is it B?
Yes, it occurs after a streptococcal infection. So we have rheumatic fever and we have acute glomerular nephritis. So GI system, when you think GI, think anything from mouth to anus. That's all considered GI. So you're going to see vitamin, mineral imbalances. You're going to see problems with nutrition, not being able to be absorbed. So then you're in growth failure or failure to thrive. It could be due to many reasons. You know, we know like cystic fibrosis, we need enzymes for the child to be able to get the nutrition that they need. And we're going to go into celiac disease, same sort of stuff, and vitamins that are being lost. So be aware that nutrition is number one. Nutrition, nutrition, nutrition. Now, food allergies are very common with infants, and children don't tolerate everything. And it could start in the very beginning with just the formulas. Most parents who breastfeed, the mothers who breastfeed, usually you don't get allergies from that. Sometimes you get intolerance to foods mother has eaten, but it's not an allergy to the child. Now, sometimes children are allergic to lactose, right? So they're on formula and they're having, now if they have a rash like this, it's easy to tell because that definitely, there's an allergic reaction, something going on. All right. The only thing they're eating as a newborn for the first 6 months is what? Just milk, formula. So we know that we need to change the formula. Could be a rash. Sometimes it's just under the neck, just in the bends of the arms or the knees that you might see it. Or you just might see a child vomiting or having diarrhea, and those things could give you that food allergies. Now, GI dysfunction causes a lot of things. I think the biggest one that I get concerned with GI is that little spit up, that regurgitation. You know, this is calories that these infants have eaten, now they got rid of. So they're not getting all the nutrition that they need. You know, they can have nausea, vomiting, diarrhea, constipation. They can have all of these things. Also, what about dysphagia, dysfunctional swallowing? Remember, mouth to anus. These are things we need to be concerned of when we're thinking about GI issues in our infants and children. Now, dehydration is the most concern when we talk about conditions with fluid balance. Children do not tolerate dehydration as adults, and it needs to be treated very seriously. Now, this is a great picture I found. And if you look at that child, number one, you see that fontanelle sunken in, right? That's easy. But the child's just sitting there, not crying, just sitting there, and even sitting up, and this fontanelle is sunken. That is the first sign of dehydration. Now, the second thing is just by looking, is look at the color of that infant, pale. You don't see pink in the ears, around the nose. You see a very pale child. Now, if you looked further, if you could closer, dry membranes, tenting of skin, no urine output, elevated heart rate, you know, low blood pressures, all of those things that you're going to see. And, you know, dehydration can be caused by many things. I mean, we think of those vomiting, diarrhea things, but sometimes the kidneys just work too good and too much urinary output. Sometimes it's that sweating, you know, the kids go out and sweat and run around and they don't replace, that can cause it. You know, that's something that should be easily corrected. And then ketoacidosis can cause dehydration. And we know burns does burn the tissues, so it gets rid of fluid also. So monitoring intake and output with children, you know, and your adults is really important. So how do we measure it? Well, urine and stools, of course. Vomiting, if we can get it in a bucket, I mean, the adults you can easier, but with children it's harder. Sometimes you have to estimate. Sweating can also be profuse in some conditions. So we would have to monitor that closely. Just like we measure diapers for urine output, sometimes we have to put like a chuck underneath them and weigh the chuck before and after and figure out how much urine came out. So sometimes we have to monitor that closely. We know the skin turgor, the vital signs, the body weight. I mean, that's how we look at fluid balance in children, is their weights. And that fontanelle, we know it's bulge, we know hydrocephalus, we know it's sunken, we know that there's some sort of fluid problems there. And older children, not the young ones, tend to be more lethargic and not as alert when they're really severely hydrated. Now, there's all sorts of diarrhea for many different reasons. So how do we treat it? Well, let me tell you this. You get a child with diarrhea, you want to just give them liquids, right? Now, or just IV fluids. So if you only gave liquids or IV fluids, tell me what is going to happen to that stool? Is it going to get formed? There's nothing to form it. So diarrhea, unless they are severely, lethargic, these children are all going to continue to eat. We will give them oral rehydration, as in Pedialyte, even for infants, Pedialyte, Powerade, Gatorade, those things we will be given, and we will be giving them food. Now, if they're vomiting, we will not give them oral, we'll give them IV, because you give a vomiting child more, what's going to happen? Give it by mouth, it's going to come right back out. So diarrhea, we're going to orally rehydrate, and we're going to give them a diet. Of course, bland, no spices, things that will go down easier and then reintroduce to normal diets. Now, children do get constipation. Sometimes it's due to a condition, but I've actually seen children under a lot of psychosocial stress, as in the father left, they moved to Florida, they're from New York, grandma didn't come. I mean, all of these things. And I've seen it with 4 and 5-year-old kids, 3, 4, and 5-year-old kids. They hold their stool for 7 to 12 days. 12 days was the longest. And I'm like, you counted 12 days? And they go, yes, 12 days they have not stooled. Well, then you ask, is there anything going on in the house? And they told you, well, they moved and their daddy left and this and that. Well, let me tell you, children, this is how they cope when they're going through these stressful times, because they want attention. You haven't stooled for 12 days. Now you're going to be the center of attention, and you're going to go with mommy or daddy or whoever, and get care. So now you're on the front burner, and that's what they want. They want that attention. So psychosocial stress does affect the stools on children. Now, what if you haven't had a stool as a newborn infant? You're just born. There's no meconium that you've seen within 24 to 36 hours after birth. Well, there's a couple different diagnoses you might see. There might be something physical like atresia. There's a closure in the intestines, or a narrowing, that could be. But Hirschsprung's disease, we're going to go in that more in just a little bit. Hypothyroidism, you need the hormones from the thyroid in order to function normally. And we know they also need their thyroid hormones for cognitive things that, they need it to be able to act just like an infant should. And it also can be due to cystic fibrosis. So if we didn't know the kid was hypothyroid, or we didn't know the kid was cystic fibrosis, this might be what shows us to go looking for it. No stool, and then we'll find it. Now, constipation can occur without all of that stress stuff. It's usually more in formula-fed infants than it is in the infants with breastfeeding. Now, formula fed infants, if it's constipation, we usually the intervention is, give a bottle of apple juice or give them a little bit of prunes or, yes, they don't tolerate it, but what it does, it comes through their system and that clears up the constipation. They don't like to give enemas. They don't like to do, suppositories. They like to do it as naturally as possible. And sometimes it's an allergic reaction to formula they're getting, so they might change formula. Okay, so Hirschsprung's is one of those diseases that you might find at birth with no stool in 24 to 36 hours. So Hirschsprung's disease this is a picture of your large intestines, the ascending, transverse, and descending colon. And that little tiny little thing that's hanging out goes right to the anus, okay? Now, it's called a congenital aganglionic megacolon. What does that mean? Well, aganglionic means A without, ganglions, nerves, no nerves in the colon. So there's no peristalsis, there is no pain, and all of the contents of the GI tract go down, sit there, and it stretches because it can't be moved down. There's no nerves to function. Now, sometimes there's stuff in there, and you might see a little bit of ribbon squirted out, just like you have like one of those cake decorators that you squirt to decorate cakes. Well, that tiny little ribbon stuff, that's what you see because that little tiny thing in the bottom, a little might squirt out. So in Hirschsprung's disease, you've got this sac of intestines that doesn't function, doesn't have nerves. So what do? We'll do a barium enema. We will do a rectal biopsy to look for those no nerves. Once we determine that, yes, for sure, it's Hirschsprung's, they do surgery and they're going to end up putting a colostomy on the infant. Now, this colostomy is temporary. They can reverse it after a couple months, okay? And they usually do, and these children do well. But that big dead bowel, they do remove it. Now, vomiting, children, very, normal thing that kids do. But what do? Nursing management. How do we take care of vomiting? Well, if a child is vomiting, you're not going to give them anything by mouth because what's the kid going to do? He's just going to vomit what you just gave him. And maybe you're going to make the vomiting worse. So, number one, NPO. Make the child without anything to eat or drink. Start an IV, and if we are going to give a bolus of fluid, because let me say the heart rate's up, the fontanelle is sunken, the blood pressure is low, the capillary refill's prolonged, etc., we're going to give a bolus, only normal saline. We don't do any dextrose with a bolus. Now, after we give the bolus, because the child's not eating, we'll give an IV fluid that has some sugar in it because the kid needs the sugar. And because of vomiting, even the diarrhea, if it's profuse, we're always going to do that metabolic profile to look at those electrolytes, make sure the potassium is okay. Now, gastroesophageal reflux, GERD, okay? GERD is when the food is in the abdomen, in the belly, in the stomach, and it moves up and goes up the esophagus. Now, what's pretty interesting is if you have an infant who has reflux, you're going to know. And I'll tell you why. You're going to feel them arch. You can actually feel the food coming up their esophagus, and their legs are going to start to move and they're going to arch, and they're refluxing. I mean, there's ways. Can we prevent it? Well, burping them well, not overfeeding them, sitting up after foods, all of those things can help. But sometimes, even with all the medicines, and we give the same medicines for adults that we do children, we just give, again, smaller doses for children, milligrams per kilogram versus one pill here. We don't do that. Now, Sometimes the reflux is so bad, medicines aren't working, they're losing all of their nutrition. We will go and do a surgical procedure, and that's called a Nissen fundoplication. Now, you might have heard this on a child who's also had a gastrostomy tube placement. Because when you put a gastrostomy tube in, you put in a bolus of 200 mLs and it goes in quick, right? So the stomach all of a sudden is full. You don't want it to go up into the esophagus and you don't want them aspirating it. So that's the other way that you hear it. But the Nissen fundoplication keeps the food down in the stomach. You do not vomit if you have a Nissen fundoplication because the stomach is curved, so it can't go up into the esophagus, so it holds the food down. Now, there are some children that are older who have reflux. How would you know? Well, if you have an older kid, it could be 4 or 5, having this, reflux, they would be complaining that their tummy hurt and pain, like right in the mid of their abdomen, but they'd have a chronic cough. And why a chronic cough? They're aspirating. That cough is the food coming from the stomach up the esophagus and going into the lungs. So the cough would be something's going on and it could be reflux. So sometimes that's your telltale sign is a cough. Appendicitis, it's the same thing, adults, children. I mean, appendicitis is usually 6 months. I've seen the youngest one, and it goes all through, life. It could be young children, old children. Usually it's that, school age to adolescent, you see the most of them. But again, you can see them at all age. McBurney point, same as adults, same as children. These children, if you see them walk into the emergency room, if they're walking, you'll see them bent over a little bit to the right. They'll be holding their right upper thigh and sort of limping on the right side. Usually you see that this kid has an appendix. So what do we do? Once we determine it's an appendix just by an ultrasound, these children are made NPO, start an IV, and they're sent to the OR. Now, sometimes the parents waited too long or the appendix bursts too quickly, and now we have a ruptured appendix. And what has happened? Well, the contents from the intestines, from the appendix, spews into the abdomen, and it makes the whole intestines angry, angry, angry. So how do we treat peritonitis? Well, it's an itis, which means it's an infection. So IV antibiotics. The intestines is angry, NPO, nothing to eat or drink. Now, also because of the amount of angriness and redness, and because of this toxin in the belly, they put an NG tube in these children. This is to keep that intestines empty, and they'll put it on low intermittent suction. Now, this kid's surgical. They still need to get up. They still need to get out of bed. They still need to walk, cough, deep breathe, prevent all of those post-op complications. And the other thing we do is make sure you check that dressing. Remember, you've taken an abdomen which is contaminated with the appendix, contents. So the skin may not be the best skin. It could have the infection in it. Many times these incisions will dehisce. They'll open up on you. So make sure you're checking that dressing and that incision scar. Now, Meckel diverticulum is this little piece of tissue inside the intestines. And inside that little piece of, like this little flap of skin, there is a blood vessel. And sometimes it rips. So the blood vessel is ripped open. So what do you see? The clear-cut things that you'll see is painless rectal bleeding. You're going to see the blood in the intestines, but you feel their belly, it doesn't hurt. And that usually clues you into that's what it is, and it needs a surgical intervention. Now, IBS, or inflammatory bowel disease, what is this? Well, there's Ulcerative colitis, there's bits and pieces, and Crohn's, yes, but inflammatory bowel disease is mouth to anus, anywhere in between. That is an inflammation. And this requires good nutritional support. Most of the time in these flares, these children get steroids, to decrease the inflammation, but they are always on, a diet that's very soft to their belly, and they're usually set up certain things to avoid. Ulcers, peptic ulcer disease. You're saying children get ulcers? Yeah, they do. You have some children that are the worriers, and they do get ulcers. Now, I've never seen one go to the point of surgical intervention. Usually they just go on the medicines, the Zantac or the Pepcid and the Prevacid, all of those medicines, again, in children a dose, and they do work for that clearing. Hepatic disorders, you're thinking hepatitis could be caused by many reasons. We do give a Hep B vaccine, but it doesn't mean they may not have a problem. So these children, we need to know how to take care of them. And one of the things is their diet. Now, hepatitis has to do with, your liver. And what's the liver do? It produces, bile is one of the things, and they help digest the fats in the food. So hepatitis, a diet that we're going to give these children, we're going to give them high in protein and high in carbohydrates. Protein is big for the muscles. When you think protein, think of the muscles and keep them working well. And then, of course, carbohydrates is all that energy they need. And again, no fat, because they can't digest it, and it just causes a lot of gas, a lot of abdominal distension and pain. So as I said, mouth to anus, what's the mouth? Cleft lips. Cleft lips are something that happens during the embryological development, and it doesn't close, whether it's one side of the lip, two sides of the lip, palate, or no palate. They can all different types. So we like to get that lip corrected as soon as we can. We will do that about 2 to 3 months. These children, what do infants do? What calms them down? Oral, right? Can they suck a pacifier? Can they suck a bottle? Can they nurse? Can they breastfeed? It's a very difficult thing for them. So we can correct it as soon as we can. It's better for the child. Now, see that little metal thing that's around that kid's lip? That's to prevent the kid from hitting and smushing that lip against the pillows, etc., the sheets, so that it doesn't rip it open, because it's a true and real plastic closure, because you don't want to see any of the scars there. Now, the palate, or the hard part of the palate in the mouth, we usually do that somewhere 6, 8 months to 12 months, usually before they really start talking. So the latest would be 12 months on them. And the reason is, if we don't do it earlier, if we don't get it done before they start talking and do it earlier, it's going to have a really pronounced effect on their speech development. They will talk like that if they were older, because they can't make those sounds with no palate there. So these children, the problem with having a palate that is open is there's no blockage between the top of their mouth and their nose. So what happens when they're feeding, milk comes out their nose. So these children, you have to be very careful with feeding, holding them up, and be, really monitoring that coming up. Now, feeding these children, as I said, how are you going to breastfeed? How are you going to bottle feed? Well, breastfeeding requires a mother with a load of patience. These children can't suck. There's no way to get a seal. There's no way to get that, what they need to get the milk down. So these children, usually mom is pumping her breast, smushing it to try to get milk in that child's mouth. Many parents decide just to pump and to give it in a bottle. And you're saying, well, the bottle, they can't make a nice tight seal either, right? Well, if you look at these Haberman bottles here, was developed by a mother of a child who had a cleft lip many years ago now. And that top part is very soft, very soft. And when you turn over the bottle, the milk fills up with it. And slowly you're pinching that area that's sticking up by the nipple into the mouth as they suck. And this can get a child that feeling of their sucking and swallowing, giving them that comfort there. Another condition of the GI tract is esophageal atresia. The esophagus, A, means without. That means there's no connection between the esophagus and the stomach. There's none. There's an esophagus there, but there's no connection. Another thing that usually happens together is called tracheoesophageal fistula. So there is the trachea, and the esophagus, and there's an abnormal connection between the both. So what happens? You swallowed in the esophagus, right? And it goes directly over through the fistula into the lungs. So this child cannot eat until this is repaired, because your food, even your saliva in your mouth, is going directly into the lungs. So these children are at chronic risk for aspiration. So these children will be on an IV and given antibiotics because of that aspiration, which is chronic. Their head of the beds will be elevated and you will have suction at that bedside, okay? Nothing by mouth. When they get older, they do their repair. In the meantime, you know, depending on how quick they can do it, they might have to put in a gastrostomy tube for feeding, or they just might give IVs or hyperal. But once they fix it, these children do really well. They're absolutely normal in every other way. There was just a misconnection between, you know, the trachea and the esophagus. Another thing that can happen is hernias. You know, we've seen inguinal hernias. Children, one of the biggest thing is umbilical hernias. I mean, if you ever had a child with a big umbilical hernia, take your finger, you push it in and out, it's soft, doesn't hurt, it tickles the kid, it's no big deal. Now, what happens if all of a sudden this nice little thing you're pushing in and out and it's sort of soft and the kid, you know, is giggling, all of a sudden it hurts and it's hard and it's painful? Well, that intestine has twisted and it's strangulated. It is now a surgical emergency that needs go in, and they need to repair that hernia and they need to untwist that intestine so that it doesn't die, because that's what will happen. Now, one of the most difficult of all hernias is what we call a diaphragmatic hernia, which means the diaphragm didn't completely develop. So it doesn't hold the intestines down into the abdomen. So the intestines go up into the chest. This child will have no left lung because it's never had the ability to develop, because the intestines are up there pushing against it. And if you look at it, it pushes over against the left lung. So there's even a compromise in the left lung and oxygenation. These children are extremely ill at birth. They have a hard time oxygenating. Many of these children end up on ECMO, the machine that gives them oxygen. It's like a heart-lung machine, but it's just oxygen. They do repair it several days once they get these kids, you know, stable enough and oxygenated enough, and they do pull the intestines in and close it up, but they never will have a left lung, okay? And they always will be concerned about their respiratory status. Now, one of the vomitings that infants can have, usually 3 weeks to 3 months, you see it, is when a child, you know, comes in and says they're vomiting, and you ask, is it like just dribbling, or does it come out of the mouth across the room like The Exorcist? Well, pyloric stenosis is forceful. You literally can have this vomit go 10 feet away from them. It comes out forcefully hard. And be prepared, because you will be splattered. What happens is the pyloric sphincter becomes thickened, muscular, and doesn't allow milk to go into the small intestines. So the stomach fills up and all of a sudden it can't hold anymore and it comes out forcefully, and that's that vomiting. Now, once I ask a parent how they're vomiting and they tell me it's forceful, it's across the room, I'm going to feel their upper middle abdomen. And I'm going to feel, you almost feel like a little olive there. And what that is that sphincter, that pyloric sphincter, you can feel the hard swelling and the muscularness of it. And you could feel it there. And you're like, okay, surgery. So they take them to the ultrasound, they find out that's going on. And what do? Well, these children are hungry because they're trying to eat. Nothing's going into them. So these kids are hungry, hungry, hungry. So they would eat as much as you give them. But what's going to happen? It's just going to vomit. So we make them NPO. We give them an IV and get them prepared for OR. Once they have surgery, and we'll be giving again these kids because of vomiting, we'll be giving, and initially we'll be giving them antibiotics because they probably maybe have aspirated also, that coming up the esophagus, there's that possibility. So NPO, start IVs, send them to the OR. They're usually home the next evening. And we start them back with just clear liquids, see how they tolerate. And there's usually no long-term effects from this because they have fixed that little narrowing, and these kids eat well and there's no problem. Intussusception is the intestines that literally sucks up into each other. 3 months to 3 years. The youngest I ever saw was 5 months. Now, what do you see with intussusception? Now you've got this intestine sucked up into the other one. It is extremely painful. This child will be screaming, yelling in pain, and those legs will be just going nuts. They'll be kicking. And if you touch that abdomen, it will be tender. It'll be hard. You can tell something's going on. So we'll do an ultrasound, we'll find it. And then what we do with that is we'll send them, sometimes this intussusception, it'll come up, and then by the time we get an ultrasound, it's come out already. That's the good one. That one we can send home. We can put them on increased fiber, and the intussusception will stop occurring. Sometimes it's stuck there and it's swelled and it can't move. That child will need to get an air enema by radiology, and they pump up air with a catheter into the rectum. They pump it up until it pops off that connection, that intussusception. And then in a very few cases, you might see them going to surgery because they can't disconnect it, and they're going to have to remove that piece of damaged bowel there. Malrotation and vulvas are two different things, but they are basically the intestines either making a knot unto itself or it's wrapping around something. And the signs and symptoms of these are, if you have a knot and you can't move the contents of the bowels downwards, you're going to see it get bigger and bigger, and you're going to see it burst. And then, of course, you have peritonitis. So this is the one, it's both of these, very difficult to be able to diagnose. But it looks like intussusception, but they find out it's malrotation or vulvus. Now, when you were in OB, they taught you to do a rectal temperature on your infant, right? Because you wanted an accurate temperature. Well, they're also doing it because sometimes infants are born without an anus. It's called an imperforated anus. And you see that picture there? That's an infant that does not have an anus. Where's all this stuff from the mouth and everywhere going? This kid needs a colostomy as soon as they can do one. Now, there's also fistulas that can occur in the private parts of a male or a female. It could go from the colon into the vagina, colon into the bladder. It could go from the colon into the bladder into a male, and you see like stool with urine coming out as urine. I've actually seen the colon going into the vagina and seeing stool coming out of the vagina. So just being aware that these things can occur with these infants. Celiac disease, another condition of the small bowel, and it has to do with gluten. Now, these children who become adults, wheat, rye, and barley, they can't have it. So basically bread, right? So bread and bread type stuff they can't have. If they do eat it, they get severe pain and cramping, and basically it becomes not worth it for these poor little children. They have an inability to absorb fat. So these children will have these extremely foul smelling stools. They call them malodorous, but it's horrible smelling stools, and it will be very pale in color. So how do we treat this? Well, this is treated with diet, and low gluten is what we do. Now they can eat a lot of foods. They can have dairy, they can have eggs, and they can have fruit and vegetables and any sort of meat or chicken, but no noodles, no macaroni and cheese, no breaded stuff, no sandwiches. Those things they can't have, but there's many things they can. Short bowel syndrome. So when a piece of bowel had to be removed because of some reason. Now, I had one patient, little Jessica, who ended up with something called necrotizing endocolitis. It's basically she was being fed, the body, the intestines didn't tolerate it, and it died. That piece of intestines died. Whether it was a lack of oxygen, something happened. So it died. And by the time we did surgery, 58 centimeters of her small intestines was removed. She had about this much left, like hardly anything. So all the absorption she wasn't getting. That's called short bowel syndrome. So you can see what the problem is. Nutrition. Nutrition is a huge problem with these children. So these children will be sent home with a central line, hyperound lipids at night. They'll have on a G tube to be able to give food, in that tube. And they can eat by mouth, but it's not enough. So they have to supplement them in every way possible. Another thing here that's listed is gastroschisis. Now, there's two things. There's bladder exstrophy and gastroschisis. Basically, the bladder is born on the outside of the abdomen, or the stomach is born on the outside of the abdomen. These organs still function. The stomach still is connected to the intestines. They're still fine, but they're on the outside. So, and the bladder, you're still urinating the same way. Our goal is to keep them, clean and to prevent infections. And they, little by little, will start to push these organs back in. The surgeon will, and finally, when they think they have enough room, they will do surgical closure on them, and they do well. And children, they're curious, everything in their mouth, right? Everything in their mouth. They just think those vitamins taste good, and they go to the shelf and they just start eating the whole jar of vitamins. Now, if it's the vitamins that doesn't have iron, you're okay. But if it has iron in the vitamins, guess what? That's a chelation therapy thing, whether it's medicine or doing more than that, depending. I've seen children eat rat poisons out of rat traps. I've seen them eat, of course, those pod things, but younger children, not the older kids that were just, doing it for the whatever. So many things I've seen them eat. So how do we treat these things? Well, you do your assessment, check your kids, see how they're doing, find out when they ingested, how much they ingested, and even nurses in the triage area, we call up poison control. And why do we call poison control? They have the most up-to-date information, right? So we can treat them. And they also will call back to see how the kid's doing, to see if there was something else going on. So children, they get into everything. And we know some things are worse than others, but as parents should have the poison control number, because they'll do it for sure. A lot of things, aren't there? Yeah. Who wants to win cahoots today? And Jeanette's going to win, right? No, Christy is. I see you smiling. Dolores? Oh, Boris is. There he is. He's ready to go. Marla, you want to win? Sean? Yeah? Maybe? Let's see how we do. Who else is going to play? Nobody feels like playing today. You're tired. GI, GU, week 8. I don't believe it's week 8 already. Multi-select. Of following are symptoms, all the following are signs and symptoms of dehydration in an infant. Which ones? Dehydration in an infant. Does it matter an infant, an adult, child? And it's everything except increased urine output. It'll be decreased urine output. What is priority treatment for a child with dehydration due to profuse vomiting? That's why I was talking to you about what do we do for diarrhea? What do we do for vomiting? Because there are different treatments here. So if you are vomiting, you're going to give IV fluids, because if you give something by mouth, they're just going to continue to vomit. So IV fluids is your best choice here. What is the treatment for an infant with diarrhea lasting for 4 days? Maybe an infant, could be 8 months. It doesn't matter how old they are. And what we're going to do with diarrhea, we're going to give stuff by mouth. We're going to give that Pedialyte, Powerade, Gatorade, and we're going to introduce food, because if you don't introduce that food, their diarrhea is not going to stop. They need something to tighten it up. So what they actually give is just a little bit of probiotics and start feeding them very slowly and making sure they have the hydration. What acid-base imbalance may you see with a child that's having profuse diarrhea? And as I said, there are about 4 questions on your HESI regarding acid-base problems and ABGs type things. So I've been throwing these in your whole course so that you can understand these. I mean, I know you have it med surg too, but very important, that I redo them here too. We know that what comes out of the rectum is more alkaline because of all of the enzymes that help digest food. They're more alkaline. So you're getting rid of alkaline, you're left with acidosis. Very good. A multi-select. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess for? Hypothyroidism, cystic fibrosis, Hirschsprung's. Yes, very good. And sometimes that's the way they find the hypothyroidism. And we know that they need those hormones or they're not going to, be normal. Deficiency of vitamin D causes what? What's the name for that? That is rickets. Scurvy is vitamin C. So remember, there are vitamin deficiencies in GI, mouth to anus. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? What do you do when they have both? And it's definitely IV fluids. Unable to eat or drink. We need to get that fluid back because dehydration is serious in children. I'll multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So remember, they've had an appendix burst. Now they've got peritonitis. This child's overnight stay just became several days up to a week. Now, complete bed rest? Absolutely not. This is a surgical patient. They need to be up, out of bed. They need to walk. They need to get their bowels moving again. So they need to be up and out. The NG suction, absolutely keep that bowel empty because it is angry with all of that toxins that are in there. IV antibiotics, infection, and then of course, we don't know the skin that was attached if it's good and healthy. And I've seen actually one of these, I've seen dehisce on an appendix. So it can happen. Passage of urine, usually at night in children who should have voluntary bladder control. And that's called enuresis. Epispadius and hypospadius are two conditions that are males. Epispadius is when instead of the opening to the urethra is at the end of the penis, it's on top. The hole is up here. The urine doesn't come out the end. Okay. And hypospadius, it comes from the bottom. And they usually like to do repair of these children before they start potty training, which makes sense, right? These children, you cannot take their foreskin. You can't do a circumcision. They need that to do that plastic closure. So that's one thing. So people in the Jewish faith with brisk, they can't do it, okay? And then they put in a catheter. Actually, it's that 8 French catheter they use for catheterization. They put it in there to keep that lumen open after surgery. And we don't do anything with it. We just make sure it's inside the diaper so you don't get urine everywhere, but it's to keep the patency of that lumen. And that's the treatment that they do for that. And it is an involved procedure, so it is under general anesthesia. So it is a big surgery. What is Hirschsprung's disease? Well, it ends up with a colostomy. And that's that congenital absence of those parasympathetic ganglion cells. Ganglion means nerves. That means absent, no nerve cells. That means no peristalsis, no feeling, no pain there. What types of stools would an infant with Hirschsprung's disease have? So remember, you have the big outpatching, and you have the tiny little tube going to the anus. And you might see it squirt out that tiny little tube in ribbon shape, just like when you have frosting that you do a cake decoration with, that big and you push it, that tiny little ribbon that comes out, that's what it would look like. Which is the condition that occurs mainly in children when the intestines telescope into itself?
I think the cat might be out of the bag on that one.
The what?
The answer was on the picture.
Just a little bit. Yeah, sometimes I do that. You know that. Give you a little hint sometimes. It's the end of the day, you know. Get a little tired. Gastroesophageal reflux disease, GERD. What is that? And remember, one of our biggest concern with this is that you're getting aspiration into your lungs. This is the biggest concern with that food moving up and down from the stomach in the esophagus. And remember, one of the treatments is that Nissen fundoplication. Inflammatory bowel disease involves what? IBS. I always call it mouth to anus. It's the way I was taught. And it's any part of the intestines, any part. You know, it doesn't matter where it is. Could be segments, could be the whole thing, depending on what condition you're talking about. What would the nurse be looking for when the patient has Meckel diverticulum? There's that little piece of tissue inside the intestinal tract and it rips. And that little tissue has a blood vessel in it. And what you see is painless rectal bleeding. Very good. And Jeanette's on fire. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? And it's that abdominal pain. Where is it? You know, is it a surgical emergency? Is it that right lower quadrant? Is it appendix? It's been going on 24 hours now. Or is it something else? So pain in the abdomen. Tell me about that first and then get the rest of the stuff. What would the nurse expect to see in an infant with biliary atresia? You know, you've got an absence of an opening into the liver. Okay, so you've got bile spewing into the body. So you could be, you know, looking like this child here, yellow, jaundice. But what does bile do to the body too, right? It's good for digestion of fat. So you don't have the color of the bile, so you have those clay colored stools. And because you're not digesting fat, it creates gas and abdominal distension. So that's why abdominal distension and why you get clay colored stools. What structure of the mouth can be impacted by cleft lip and palate? And it's everything. Cleft lip repair is typically done when? And that's a great picture of the Haberman bottle and the way that you feed it. You can see the milk there, and they're just touching it as they go down, and they little by little, and they can eat. And it gives them so much comfort. We do cleft lip between 2 to 3 months. We want that done as soon as we can because they need that self-soothing, that stress reliever, oral. They need their oral. When does a cleft palate repair typically occur? So cleft palate is before they start talking. So 6 months, 8 months to 12 months, right in that area is when they do try to do it because they don't want any speech impediment. That's their biggest concern is speech. Esophageal atresia. What's that? So esophageal atresia is when you don't have an opening from the esophagus to the stomach. I've actually seen one child with both the TEF and the esophageal atresia. Beautiful little girl. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So when you have no opening to the stomach and you have this little fistula which connects the lungs to the esophagus, we are going to be getting, even with just saliva, it's going to go down the esophagus and it's going to go in the trachea. What happens when you get something that goes into your lungs? You're going to cough, you're going to cough, you're going to choke, and you're going to turn blue because you're coughing and you're choking. Now, what's great about this slide here, you've got olive-shaped mass, right upper quadrant, visible peristalsis, vomiting. That is pyloric stenosis. Current jelly stools, failure to thrive, abdominal pain, intussusception. Sometimes you just get this jelly with a little bit of streak of blood in the stool, and then when you open the diaper with this pain, you'll see it and you'll say, yes, intussusception. Neonate with suspected tracheoesophageal fistula. Your nursing care should include what? After everything I've told you about tracheoesophageal fistula, what do you think? So we're not going to feed anything to this child because I don't want to pour it right into the lungs. Elevate the head, NPO, and suction at the bedside to keep the mouth as clear as we possibly can. Don't put anything on the mouth, no little drop of food, none of that. No, you're just going to have the kid choking. A 5-year-old is complaining of epigastric pain and a persistent cough. What would you suspect? What causes a cough? And that's that gastroesophageal reflux is going up and down the esophagus, a little bit's going into the lungs, and they cough. Very good. Signs and symptoms of hypertrophic pyloric stenosis. And this is what I look for after they tell me they're projectile vomiting. And that's that olive-sized mass, which is that pyloric sphincter is hard and muscular and atrophied, and you can feel it. It feels like a little olive. It really does. More signs of hypertrophic pyloric stenosis. Projectile vomiting. Now, somebody wanted to say poor appetite. So if I take food and I put it in my stomach and it can't go down and I vomit it out, I'm not getting anything to eat. These children are hungry. So poor appetite? No, feed me, feed me. They would eat constantly because they're so hungry and they're not getting the nutrition they need. What does celiac disease affect? And celiac disease is all about the small intestines. I put that there for that reason. And remember, it's the villi in the small intestines, which is part of what's going on there. So it is all small intestines and nutrition. Where's nutrition, taken? It's in small intestines. If you have celiac disease, what should you eliminate from your diet? Macaroni and cheese. My grandson would have a problem with that. And that's wheat, rye, and barley. They can eat dairy. They can eat ice cream, all they want, but they can't have wheat, rye, and barley. A multi-select. Vitamins that children with celiac disease are prone to lose are. So remember, these children have these malodorous stools, and they have abdominal distension. Why? because they can't tolerate fat, right? So fat vitamins, A, D, and K are all fat soluble vitamins. These are the ones that they need to replace. That's why abdominal distension, they don't tolerate fat, and that's why they're losing that. What foods would you select for a child with celiac disease? So give them a good old omelet, banana, glass of milk. That is a great thing to give. Everything else has some sort of bread in it. Phimosis, what is that? So phimosis is when the foreskin is too tight and you can't pull it back. There's another name for when it's pulled up and it's stuck there. Sometimes we have to put cold on there, some other things, and then we can pull it back up. Can you imagine taking a poor young child and putting ice on their penis to constrict it to be able to pull it up? I've had to do that before, a poor little kid. What is a hydrocele? Well, when you look at the name, you see hydro, you think water, right? Hydro, fluid, water. Usually this child will have pain, and sometimes they're incontinent on themselves because it's fluid around the testes and it irritates them. So it's painful, and sometimes they might be incontinent. This is treated with antibiotics. What is cryptorchidism? This is when the testicles don't fully drop into, the scrotum, okay? You could have one that's still up in the abdominal cavity and hasn't come back. Sometimes there's both. Now, the thing with examining these children, if you are a male and you're in the cold and you expose your scrotum to cold, it sucks it up, right? So the only time you can get a real good exam is when you have it warm, so you can see, are the testicles there or not. You suspect an infant has cryptorchidism, how would you examine that infant? So we would have them in a warm room, okay? Because we want them to be down as far as they can to get an accurate assessment of those testicles. A hypospadius. What did I say about that one? So it's an abnormality on the ventral side of the penis. So hypospadius is on the bottom, epispadius is up top. Where the urethra doesn't come out the tip, it's either the bottom, hypospadius, or top, epispadius. A multi-select. How is a hypospadias corrected? So we'll use that foreskin as that plastic closure to cover that opening. We'll put that stent in there to keep that lumen opening, and it's not done under local. It's a general anesthesia, and they like to do it before they're potty trained. What is a bladder exstrophy? And it's that midline closure doesn't happen and the bladder is on top of the abdomen. Again, it all works well. Our goal as nurses, if we see that, is to maintain that we don't get an infection there. What are the clinical manifestations of nephrotic syndrome? Remember, has nothing to do with kidney failure. And it's hypoalbuminemia, low serum albumin, and of course that swelling proteinuria. This is something treated with corticosteroids, prednisones, and of course nursing management would be daily weights, intake output, and monitoring fluid and salt. Children with nephrotic syndrome are often given what medications for fluid overload? So you have a lot of swelling, extracellular swelling. How can we get rid of that fluid? We give protein, which is the albumin, put it intravascularly, and it pulls the fluid in. Then we give some Lasix, diuretic, and we push it along, and then you urinate it out. It works actually really well. What is used to treat nephrotic syndrome in children? And it's prednisone. Very good. What is the priority nursing care of a child with nephrotic syndrome? And we are going to monitor daily weights. Increase salt intake? Oh no, because you're already swollen and edematous. You're going to decrease salt intake, minimize it as much as possible. Why is erythropoietin used in chronic kidney failure? Because it helps with red blood cell productions, because hemoglobin hematocrits are low, and we could do that without blood transfusions. A multi-select. A child with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Well, osteo is bone and dystrophy means not right. You know, it's malformed, all right? And it's the kidney the skeletal abnormalities. Of course, you're not growing as well as you should because those bones are being crooked. They're not going right. And then there are high parathyroid, which is all about calcium, too much calcium in these children. A diagnostic finding of acute glomerulonephritis may be what? I mean, we know glomerulonephritis is caused by strep infection. Which one of those say that? It's what we call a positive ASO titer or anti-streptolysin. Okay, strep, that's your key thing there. ASO titer. Sometimes you see it written this way, and that's why I put it there for you. I've seen it on exams that way. Which complication of peritoneal dialysis is most important? So we're concerned about peritonitis. That is our biggest thing because it's working like our kidney. If you don't have the abdomen, what's going to work for the kidney? There's nothing else on these small children to work. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? And I saw one of these kids was running around and he ran in the backyard and there was a trailer with a hitch there. And he was coming around backwards and he banged his back right at the kidney level. And he had this bruise, this huge bruise. And the one thing that was remarkable, his potassium, I think, was 7.2. So yes, just because they have trauma, you think kidneys, yeah, always potassium, but even trauma, you will see it. That you'll know, according to that level, how much trauma has gone on to that kidney. A multi-select. What should the nurse anticipate for a child who just had a renal biopsy? You know, I think renal biopsy, it's the same thing as a cardiac cath almost post-procedure. So we are going to monitor intake and output because we've touched the kidney. We want to check that. Dressing to make sure it's not leaking. And this child will be on bed rest for 24 hours. Absolutely not out of bed. Just like cardiac cath, not out of bed. We don't want to have that clot rupture and then cause urine draining into the belly or, you know, onto the bed. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? Number one, notify the provider, get those antibiotics and get them started. Save that abdomen, that peritoneum is needed. What would the nurse provide to an infant that cannot eat normally? Maybe it's that child with tracheoesophageal fistula, right? They can't eat because it'll go right in their lungs. What are you going to do for that kid? And we're going to give them a pacifier. We're not going to do vigorous mouth care because you're going to stimulate saliva. You don't want to do that, especially if they can't eat normally, there's a reason. So pacifier, so important. It's normal growth and development. Number 3 is pink. Number 2, and Jeanette. Good job, Ann Jeanette. Pink. Number 1, R. Kahoot and an LJ. What I'd like you to do is please sign your attendance attestations. And remember, I know your case studies have zeros. I'm checking on it. So if you still see zeros and haven't been contacted by me, it means I'm finding your grades for you. When something goes on, I will let you know if I can't get your grades and I'll send you a message. So don't stress, you're going to get your grades. I promise. I know how hard you work for them. So thank you, everybody. You have a great evening. We did good today.
Thank you.
No, you're welcome.